Good evening, ladies and gentlemen. We would like to welcome all of you once again in the Academy of Motivation and Education, in our program for Ukraine. As some of you already know, for unfortunately 2.5 months, we have been organizing a series of these brief, intense trainings for professionals in order to learn about the specific ways of working with trauma. Our fantastic lecturers share various practical tips on how to work with people who have experienced war trauma. Today, we have a great pleasure of a very well-known, it's hard to believe actually that here with us is Professor Emily Holmes from the Oxford University in Great Britain, who is in Sweden at present at the university in Uppsala, but also in the Karolinska Institute. She works there as a clinical psychologist and neuropsychologist, as I understand well, right? And she deals with very important research related to intrusive memories of trauma. It's a very serious topic, very difficult topic for those who have experienced it. And we want to learn how to support those people in coping with those memories of trauma so that they are not so destructive. Welcome. And thank you. We're very thankful for you being here and your positive attitude to supporting people who experience trauma. Thank you very much, and the floor is yours.
Thank you so much, Iga. It's a pleasure to be here. Thank you for inviting me, and thank you for all you are doing. I understand there's already over 3 million refugees from the Ukraine in Poland. So a heartfelt thanks to each and every one of you working so closely with this incredibly important and difficult situation of our time. And so I'm very grateful to what you are doing in Poland. I'm going to share my slides in a moment. But before I do that, I just wanted to say we will have this lecture today, but please interrupt me any time with questions. It could be just a clarification or to ask something or to make a point. It's a flexible lecture today, and I'm very happy to take questions. Okay, now I'm going to share my screen and I'm going to put the slides up, and then I have to always do this thing of swapping the screens. There we are. I hope you can see it well now. Good. So we're going to talk about intrusive memories after traumatic events. And it's very nice to be a part of your training program. I'm based in Uppsala in Sweden and affiliated to Karolinska, and I'm very grateful for you bringing me here today, Iga, and for our connection via Robert Leahy in New York, and for all of you for giving up your time to come and to share ideas together. When I'm speaking to you, my background is both as a clinician, I'm a clinical psychologist and CBT therapist, and I'm also a researcher and academic interested in mental health science. And I'm always really interested in where we don't really have treatments and what we could do in new ways. And the particular area that I'm interested in is mental imagery, so our imagination. And that also relates to memories of trauma, things that we remember and see in our mind. As I said to Iga, I have not been to Poland, but I'm really looking forward to coming to the first time in November. So if you want to have a continued discussion, I'll be very happy to continue this in Warsaw in November. I also wanted to give some context on what I'm going to say today. I was actually in Odessa in Ukraine in 2018. And when we visited the beautiful city of Odessa, it was at the invitation of the NATO Science for Peace and Security series. And there was a series of people working in trauma who met at this meeting. And the purpose of the meeting was to take forward this guideline, which is sadly ever too relevant now. And the guideline is on the risk management of terrorism-induced stress, guidelines for the golden hours. And what the term golden hours means is very soon after a trauma, so very soon after a bomb or an attack or a massacre or whatever. And so the people who my colleagues from clinicians from Odessa, particularly Irina Frankova, and these same colleagues here have just published a piece that may be of interest. You can download it freely from this DOI in the Lancet Psychiatry, calling for more trauma support tools to the Ukraine, which is exactly what you are all doing in Poland, which is fantastic, and also the potential to increase digital support tools. So I just show you this slide out of interest here. They have also developed a chatbot with instructions in Ukrainian around psychological first aid. And I know in your series in Poland, you've also talked about psychological first aid. So I thought you would find that of interest. So that these details are here on this link. And what we've also done, and this is just to refer you to some cases, if you found anything I talked about today interesting, my colleague Sophia from Ukraine and Irina from Ukraine and the head of the medical psychology department in Kiev talk a little bit about their cases working with intrusive memories after trauma in Ukrainian. So ignore me because you've heard me already speak today, but you might want to come to this link and particularly hear the clinical cases here and here. And I hope you find that of interest. And at the end of my talk, I'll put up some references again, because I know when I'm doing clinical workshops, I always want to have some reference material. So I'll put this slide up at the end too. A lot of what I talk about today and is going to be practical tools and also stuff that's not necessarily in exact clinical guidelines, but that we're in a war situation. And so therefore, many of the things that I'm sure you're working with aren't always inside a simple box. But I wanted to put up this caveat that the research studies certainly are at an early stage and proofs of concepts. And what I hope you take from this lecture is some clinical practical tools for managing situations beyond the current evidence base and where our resources are lacking. So the context is the ongoing war in the Ukraine. And we're going to talk about intrusive memories and working with them and end up on ideas for the future. And one thing that I wanted to remind of us is this is a picture of the world and traumatic event exposure before this particular part of the war in the Ukraine started. So this paper is from 2016. And you'll see even then that the Ukraine had the highest rate of trauma exposure of any country surveyed in the world. So that means that when we're working with our fellow citizens from the Ukraine, it's already with the backdrop of a lot of trauma exposure, even before this war. And as clinicians, what we all know is that trauma is the biggest factor is not the person or even necessarily the type of trauma, it's how many times you're exposed to trauma. Trauma is a dose-wise response. So please bear this in mind that the current war may also be bringing back intrusive memories of past trauma in these situations. And this is for sort of international context. So what are intrusive memories after trauma. It's helpful for us to always understand the phenomena that we work with in some detail, as that helps us work with it even better. So that's what we'll talk about now. Intrusive memories are defined as recurrent, involuntary, and unwanted recollections. They're typically during the day, but they can also occur when they're very repeated of the same event in the form of traumatic nightmares. In the DSM, our diagnostic manual, they occur within the criterion B for PTSD as an intrusion symptom. But what's important, I think, now to think about is that they can occur before a diagnosis of PTSD is possible, so in the first month, very common. And they can also occur without other symptoms, so by themselves in a sort of preclinical or a subclinical population, also be very distressing. What we know from the data is that many may spontaneously remit, but if they do persist, they can persist for years or almost decades. So they're really important things to pay attention to and to try and do something about. Intrusive memories do occur in PTSD, but of course they also occur in many other psychological disorders, not just PTSD. So they can occur in acute stress disorder, in complicated grief, which is very relevant in a war situation. You can have intrusive memories of negative events in major depressive disorder. For example, the intrusive memory can be very similar to a sort of intrusive memory in PTSD, but perhaps the content is very different. So rather than the content being about something frightening or shameful, in depression it may be around loneliness or loss. Intrusive memories are all too frequent in psychosis, and trauma can precipitate, as you know, a psychotic episode. And they're very prevalent. We've done quite a bit of work in bipolar disorder. So intrusive memories are very prevalent in bipolar disorder, something that also has been increasing and we know is much higher, 5 times higher in refugee populations than in general populations. And intrusive memories are also common in borderline personality disorder. And one of the cases on the Ukrainian link that I gave you earlier was my colleague Sophia working with intrusive memories of the current war in a patient with a chronic condition and long-term history of borderline personality disorder. So what I wanted to illustrate with this slide really is that please don't just think about PTSD. Intrusive memories of traumatic events can occur in many disorders, but perhaps their treatment or the way we could help mitigate them could be quite similar in different disorders. And I put up this little network diagram because I think because there's increasing evidence that intrusive memories can be a precursor, so come first, and then the disorder worsen later, it's really helpful to find ways to get the level of intrusive memories down and in people's control. So let's give a clinical illustration, and this is a fictitious example from Ukraine. A patient might have several different intrusive memories. In our research, people may have approximately 3 different intrusive memories of trauma. So not 100 different memories, but perhaps in a war situation, it may go up to 1 to about 12 or 15 different memories. And an intrusive memory of trauma may be described, for example, as the sights and sounds of the first bomb blast next to my home. That might be 1. Or seeing the soldiers outside my window. That might be number 2. Or seeing a child with blood on their face. That might be number 3. And why these little fragments? Why these particular, as it were, snapshots that come to mind? Well, they tend to be, if you think about trauma as an ongoing event, they tend to be like almost volcanic hotspots, like the worst moment or just before someone realized it was about to be awful, like the soldiers were about to do something, or the moment you realized disaster was happening. So it's as if the brain is trying to capture these moments and save them to protect the person from future harm. And as I said, it's worth bearing in mind that people often have several, but it is usually a treatable number of different memories, different pictures. So if your patient says, I have this one picture, it's always worth saying, and do you have any more? The other clinical question that's really important for us is, how often do these intrusive memories occur? Well, in the kind of cases that we've talked about and in refugees that we've worked with, it's quite common to have anything between 1 and 30 times a week. And remember, for a diagnosis of PTSD, you don't need more than 1 a week to qualify. But 30 times a week can be common, sometimes more in even newly arrived refugees. But our clinical tools, sometimes we get a bit stuck with here, because for those of you using things like the clinician-administered post-traumatic stress scale, the gold standard in PTSD, the CAPS, actually the maximum is 1 daily that you can score. And of course, 30 times a week is far higher than 1 daily. So I just wanted to share that kind of that range of what's the sort of thing you might be looking for. And probably, sorry, just before I go to that, the other clinical thing is that with all the work we've done over the years on imagery, it's always worth asking if somebody has intrusions and intrusive images, because people often don't tell you that they're having images pop to mind unless you ask them. In our everyday language, we don't talk about images and pictures unless we're artists. So it's not normally part of our everyday language to talk about pictures that pop into mind in our head, although we'll talk about it not. So it's really important to ask somebody, and that's why I'm trying to give you this sort of context to the kind of range and types that we might see at the moment. So let's carry on with our definition. The word involuntary is important in this definition because it means that unlike normal memory, so if I with normal memory, I can say to you, for example, Iga, can you tell me the capital of Spain? And you can tell me, deliberately recall something. But with intrusive memories of trauma, it's not about facts and being able to deliberately remember something. It's the fact that it pops up when you don't know without you being able to control it. So it's triggered not by you deciding to remember something, but by things in the environment being a reminder to the content of that memory. And it therefore can make someone feel really quite out of control, because I'm not choosing to remember this memory. This memory is pushing itself into my mind. And the word intrusive means by definition unwanted. It's against one's will, and one doesn't want to be seeing that content of the memory. Now, the other really interesting thing about intrusive memories is the fact that they're not like our other thoughts, or most of the other thoughts we're aware of. They're sensory memories. So I've talked a lot about pictures. In trauma, they're typically about 80% visual imagery. So they're pictures, sensory representations, but also in our other senses too. So they include sounds and smells, and it's almost like a mini capsule of the experience, whether that experience is a bomb blast, a car crash, or a scene in a hospital or an ambulance. Now, what does that mean to have sensory memories? I think this is really interesting. And I hope you can share this with your patients too, because often patients really like to know why they're having these strange experiences. Well, it's because they're mental images. So they're defined as representations of sensory information without the real thing being there. So it really is like seeing in the mind's eye, seeing in the or hearing in the mind's ear. And it's a different part of your brain to words and language. So when I'm speaking to you now, we're using words and language, but if you just shut your eyes, for example, and imagined an apple, the same parts of your brain, your visual cortex, which is back here, would light up just as if you were seeing the apple, but not as strongly. So when someone feels that their image is scary and it's like it's almost happening again, as far as their brain's concerned, it really is. And it can be helpful in terms of psychoeducation to let our patients know about this. I think that your brain is recreating an as-if perceptual experience. And we've shown that even if it's very brief and less than a second, images have a much stronger impact on our emotions than does thinking about the same thing in words. And if you think about it, if you think, I want to scream, that gives you one reaction. If you really shut your eyes and imagine yourself screaming, that gives you another reaction. So just imagine how powerful it is seeing a bomb blast again in your mind, even if it's only for 200 milliseconds. And these images and sensory images don't just bring back emotion, they have a big effect on what happens next. Because when an image comes into your mind, it hijacks our attentional systems, because of course it does. Your brain's wired to try to detect threat and keep us safe. So if an image comes back to mind, like I put on this picture here, then you can see that the car crash is going to take up lots of attention. And I'll show you in Refugees in a little bit a graph that shows you quite how much attention every day is taken up and being wasted by having intrusive memories. And not only does it hijack attention, it tends to impact our behavior. Again, if you're having images, intrusive images of a car on fire, you might want to avoid fires and avoid cars. So to summarize where we're at now, intrusive, unwanted memories of trauma occur across several mental health disorders, not just PTSD. And they occur in those disorders that we know are most common in people who are newly arrived as refugees. And they include depression, anxiety, post-traumatic stress disorder and associated reactions, as well as other less common but severe disorders which are increased, such as bipolar disorder. Intrusive memories are sensory representations, so they're in a different part of your brain, and they can feel like actual perception. They can pull powerful emotions, hijack attentions, disrupt our functioning, and drive behaviors and avoidance. Okay, so I hope you've got you interested so far in what they are and why they're so powerful. Now, what I'm going to talk about next is what we can do about them clinically with our patients. So, what I think we are going to talk about today is a single symptom approach to this transdiagnostic symptom, because it's in several different disorders. And we think that developing interventions that focus on one thing can be very helpful, particularly in a complex situation when there's an awful lot of people to treat or there's an ongoing war. So I will refer to, say, clinical guidelines. I'm sure in Poland you also have these clinical guidelines. I was involved in Sweden in bringing forward the PTS guidelines here, which is called the SBU ones. And these ones are available in English online. The UK, British NICE guidelines for PTSD. And they put us, they consider, if necessary, that you can have, if a patient's unwilling or unable to engage in the standard symptom treatments for PTSD, that a single symptom approach is something that one can apply. And that's even, that's in the general population. So what can we do if we're focusing on one symptom? Well, the first thing as clinicians that we need to be really clear together about is, what are we trying to do? And what would we be trying to tell our patient would a good outcome look like? And one clinical aim is to reduce the number of times intrusive memories of trauma occur. The number of times they occur per day, because they're hijacking attention and taking up a lot of time. And if we could get rid of them, then we could also free up the emotions and distress that go along with them. And we're trying to reduce the negative impact that they're having on people's daily life. How? Well, I put up this slide to say to you, and I don't know if you have this expression in Polish, but in English, we have an expression which is, there are many ways to crack open a nut. And as I'm sure, this is a bit of a metaphor that I would use for psychological treatments. Our aim is to get the nut open, or to get rid of the intrusive memories. But what I'm going to say is that there's many different ways you can do it. And what you need to do is either choose the tool that you like some people like this tool or this tool. And sometimes when we have a lot of resources, we can use a complicated tool or a very novel way of doing things, but sometimes quite simple tools are useful. So I'm going to start off by telling you about some super simple tools. And I'm sure they're very familiar to you already. And then we'll end up talking about maybe some more novel tools that might be useful in the future. So during the war, we need to think about the resources that the patient has, the refugee has, the therapist has, and our healthcare provision and costs allow. So in Ukraine, we have forcibly displaced Ukrainians in host countries like Poland. And as we discussed at the beginning, that's over 3 million people now. And we know that a percentage, we know from other refugee studies that 25% will have PTSD alone, probably, and another 20% depression. So we're talking about a lot of potential people with intrusive memories. We also might think, how recent was the trauma? Was it very soon, the so-called golden hours? Was it days or months? But actually, the techniques that we use should be as low intensity as possible and as flexible as possible for these different situations. So in theory, something that we can do is work with existing techniques for older intrusions, if there are older intrusions. And you know these techniques already, so I'm not going to go them into detail. So from our CBT toolbox, we could work both, for example, in anxiety and in trauma reactions with exposure techniques, for example, from trauma-focused CBT or EMDR. We also have very good techniques, and there's work by Arno Arntz and colleagues working with refugee populations on so-called imagery rescripting. And that is a very useful and creative tool to use, where you can take a nasty image and think about its meaning and how to change the outcome of that image by working with it almost like a film, where the patient takes control and changes the ending. And for those of you interested in rescripting techniques, we've written about that in our books, the 2 books that we've done on imagery techniques, and there are good workshops just on that. So these are techniques that we do use when we have the resources, are really interesting to use, have great evidence. But the possible limitations are, in a situation when there are a lot of people to treat, it can take a long time. It requires expert therapist guidance, remote delivery, and can be challenging in complex cases like extreme dissociation. So for some, it can be rather difficult to deliver in the middle of an ongoing war. There are other treatment techniques that have been developed for refugee situations. And as I'm sure you know, one is called Problem Management Plus, work that Marit Sabranji in Amsterdam and colleagues have developed with the World Health Organization. That doesn't directly tackle intrusive memories as part of the therapy, but in their research, what they're seeing is some longer term benefits of these kind of techniques further down the line. And I believe some of the details are available on the WHO website. If we go back to our clinical guidelines on post-traumatic stress from your sister CBT organization in the UK, the first line treatment for forcibly displaced people, as in refugees in a host country, are psychological therapies where the trauma is discussed in detail, trauma-focused CBT, including narrative exposure therapy and EMDR. And that applies to children as well. But in the clinical reality, as we talked about earlier on, intrusive memories don't just occur in the context of PTSD. They may occur in other disorders. And some people, and I would hesitate to say actually many people, do not wish to talk about the content of their traumatic experience in detail with a therapist. And maybe that's hard for us to imagine as therapists. But if we look at the literature on PTSDs, one of the things that's been a big problem is the very high rate of dropout, including therapist burnout from delivering the evidence-based treatments. It's, as I said, I'm a big believer in evidence-based, but I think, so I am still recommending them when they're possible, and the person wants to do them and the therapist is able. But I think we also need to feel compassionate about those who may not wish to do them. If it feels too distressing or too shaming, for example, or if a treatment's are being delivered at distance that it's hard to do via video conference. Some people with complex trauma that we've worked with don't wish to disclose the details of their trauma. And for some comorbidities, the evidence is unclear and less emotionally intense options may be preferable. For example, managing the risk of dissociation can be very hard to do if you're delivering your work via Zoom. And for many people, simply fleeing a war situation, what's happened to them is something that they may wish to remain private and still be at a preclinical level in terms of a diagnosis, but very distressing clinically. And for many, many people like this, as I'm sure you will be meeting, simpler options may be very helpful. So what simple options do we have? Because simple can sometimes be very powerful. Well, one tool that we have is called metacognitive reappraisal. And what metacognitive reappraisal means is simply a way of taking the power out of intrusive imagery by realizing as we're reappraising what it is that's happening to you cognitively. And intrusive memory is simply mental image in your head, your brain trying to look after you. It's just an image. That may sound obvious if you've never had intrusive memories and flashbacks, but to somebody who has intrusive memories and flashback, for that split second, you're back in the trauma again. So it's quite hard to know in that moment that it's not real. So you have to learn when you have an intrusion to be able to say, it seems real, but it's not real. Having this memory, this is the other thing that's really, really important. We know that the people for who intrusive memories persist for a very long time, they're the ones who tend to believe them more, find them very real, but also think believing that having this intrusive memory means that there's something wrong with me, I'm going mad, or I can't control it, or having the negative self-appraisals that having this image means I'm a bad person. And we know that from all sorts of research, particularly from Australia, looking at people's appraisals very soon after having a trauma and those who go on to get difficult symptoms that last for longer. So these techniques are also super important, reappraising that image. So it's not real. It does not mean you're going mad. It does not mean you're you're a bad person. It does not mean it's about to happen again now. We've just done a research study with colleagues in Germany on simply learning these kinds of reappraisals, and that's in a sample of people with PTSD and showing this much gentler way of treating. And they actually did this via a computer program, but you as therapists can just say these beliefs and help correct them with the patient. Of course, associate that in mind at the same time, to do when they're having a flashback. And we've shown in PTSD patients, if you just do this and nothing else, it helps reduce symptom burden. So in the face of complexity and large numbers, let's not ignore these very simple tools that we as cognitive therapists know very well how to use and can be simple to share with others at scale. So it may be useful, I showed you this brain picture earlier as part of doing the metacognitive appraisal to remind the patient that it's not surprised that they thought it felt real or they might be going mad or feeling guilty, because your brain's giving you an as if experience. It's a different part of your brain than verbal thoughts. And we sometimes even show people a picture of a brain scan to make that very, very clear. You can also still have a lot of people saying, well, for a lot of people this helps, but some people might still say, well, now I know it's not real and that my brain's doing it in this way, but how do I'm still not completely convinced. What do we do? Well, of course, you know what to do. You're a CBT therapist. We do a behavioral experiment. How do we do an experiment with an intrusive image? Well, we take the belief and say it's something real, or I don't have control over it. Okay, well, how can we take control? We can do things like change the color, change the size, deliberately recall it to mind, anything that's as it were, a mental behavioral experiment that teaches the patient that image is just an image. change its color, shrink it, move it far away, put an impossible object in it that's not possible to have there. And what you're doing, and remember that as far as your brain concerned, and having an image is an as-if perceptual experience. So you can do a mental imagery behavioral experiment, find out what the worst fear is about having these images, and then test it mentally. So a second really simple and effective way of taking that horrible power away that intrusive mental imagery can have on somebody. Another way to bring back control, and we know this again from all sorts of clinical disorders and from research way back in the 50s and 60s, that simply asking someone to monitor their symptom can be a big way to bring it under control. And we do that by getting people to monitor their symptom in, say, a simple diary. You could do that on your iPhone, you could do that on a piece of paper, you could do it on a card in your wallet, but just counting, okay, and understanding and noticing how your intrusions are triggered. So again, another tool that's in your toolbox that for some patients can be extremely helpful. The other sort of option that we're going to turn to in a second is more about the cognitive vaccine approach that Igor mentioned at the beginning. And that comes from a literature that we call imagery competing task interventions. And I think some of the reasons it may work may be very related to the same reasons treatments like EMDR might work, but it's what I'm going to talk to you about is going to be simpler. And these techniques might be useful both soon after a trauma as well as for days and months post-trauma. And critically, as in the other three techniques that I've just talked to you about, it does not require a lot of time nor a detailed discussion of the trauma. So before we turn to that, just to summarize where we are now in our talk, we've talked about 4 mental imagery focused techniques. We've talked about and how good our evidence base is, so please do use it if you have the time and resources: exposure, imagery rescripting. We've talked about metacognitive reappraisal of the nature of imagery and the importance of that. We've talked about symptom monitoring, and we've talked about mental experiments, like behavioral experiments showing an image isn't real. And now we're going to go to the next technique, which I'm going to talk about in a bit more detail, and that's around imagery competing tasks interventions. Before I do that, does anyone have any questions that you want me to answer on what we've talked about so far?
Nie ma na ten moment pytań na czacie, także może idźmy
There are
dalej.
no questions for now on the chat, so we can carry on.
Thank you. Okay, great. I'm glad that was clear so far. Okay, so as I said at the beginning, this next part is fresh from the experimental research, but I think, and I hope I'm sharing it with you because my Ukrainian colleagues have also told me it is being very useful, and I've pointed you to those resources as well, where they've talked some cases. So it's another tool in our toolkit for managing situations beyond the current evidence base when we have low resources. So the question is, how could we develop a cognitive therapeutic vaccine? And this is a metaphor for the idea that if something bad happens, like a traumatic event or any other thing, are there ways to reduce the amount of symptom burden that happens after that event? So a secondary vaccine, as it were. And what we've proposed is, in the face of complexity, not targeting a full diagnosis. I'm not a big fan of diagnoses. They're very complicated. But instead targeting something simpler, like one key symptom that is distressing the patient, here intrusive memories. And to develop something like a vaccine, you have to focus on the mechanisms that maintain the disorder. And here we're going to go back to what we've just learned from the psychological science point of view about the nature of intrusive memories after trauma. So what we know is that these intrusive memories, for example, the first time I see a bomb outside my house or seeing the soldier's face, they're predominantly visual mental images. And what we also know as psychologists from work going back to the 1960s and 70s is that our brains can't do 2 of the same things at once. You can't both think in the form of images and do an activity or a task that takes up imagery. And you're a psychologist, so you'll know all sorts of imagery competing tasks. If you were delivering the Western intelligence test, there's something called block design. If you were knitting, that can be a very visual spatial task. But the one that I'm going to talk about is also visual tasks that could be computerized. But your brain can't do two image things at once. So it can't hold an image of trauma in mind and do a task requiring imagery. Now, the third part of this hypothesis is that our minds don't work like video cameras. Actually, memory, human memory, is malleable, which means it can be updated and altered after we give ourselves a reminder cue. What does that mean? That means that if there is a cue, so a brief cue, not too much, not too little, to a specific hotspot moment, it means that you can bring an image or a memory back into the mind's eye again. And that bringing a memory back to mind is enough to, according to the neuroscience of memory theory, be able, if you do it in the right way, to make memory modifiable and able to alter again. And so what I'm going to have to suggest to you about the timings, that this is the way to do it, that you can make a memory active again, dampen it down with a competing task, and do it long enough that the memory shuts down again, which means what you've done is slightly alter that memory to make it, as it were, less easily perceptually triggered, and therefore come back to mind less. Now, I know this is a complicated hypothesis, so I'm going to do it again, but in a different way, but this time visually. But I think it's really important that if you want to use it, that you understand it, because you want to be able to explain it to somebody that you're doing it with. And maybe with a patient, it's easier to explain like this and just do a drawing. 1, 2, 3. Your images are, your intrusive memories of trauma take the form of images. Look, you can see this bomb blast. It's got smoke and fire in it. When you bring it to mind, your memory becomes active again. But don't bring it to mind too strongly. I don't want you to tell it to me in detail, and I don't want you to hold it in mind for too long. Just bring it up briefly so you see it, okay? Great. And now you can put it away again. So now we're going to switch to teaching you how to use your mind's eye to move things around. That's in psychology something we call mental rotation. And I'm going to teach you to do that because it's really important that we're going to engage the visual part of your brain. The visual part of your brain's back here. And we know that when we hold things in mind in our mind's eye, that really activates your visual cortex. And I'm going to teach you to do that with a computer game. This computer game is called Tetris. And whilst you're doing that, you'll find that you can't think about this visual memory at the same time. Okay? And what we're hoping it will do over time is if we do this for long enough, we're going to ask you to play this game for 20 minutes using mental rotation to move these blocks around. That after you've done that, this one memory that you've targeted will be restored in your brain in a less vivid way. That means it won't be popping back as many times as it did before. You probably only need to do this once on this memory. But if it doesn't work the first time, we can try it again. Okay? And so you can just draw out on an envelope or whatever, just these 3 simple steps. Bring the memory to mind briefly, learn how to rotate in the mind's eye, and then to play the game. And what I've done there is explain to someone the same hypothesis that we've just talked about why that should stop the memory popping back to mind. The whole procedure takes about half an hour for one memory. And I guess this is the really important thing as well. Then we talked about at the beginning, like you might have a memory of a bomb blast, you might have an intrusive memory of the soldier's face, and you might have an intrusive memory of the child screaming. So you would need to do this once for each different memory, each different hotspot. If the patient only had one intrusive memory, you only need to do it once for that one. If the patient is unfortunate to have 10 different memories, then you would do it once or twice with them, but then they can learn to do it themselves. It's not a difficult technique. So they can do it on the rest of their memories probably by themselves. each one at a time. Okay, so those ideas are summarized here. It's a brief intervention. You get one session where you would guide them and encourage them to do it. And a lot of the therapist's role here isn't to be like, it's not at all like being a trauma therapist or getting the person to be strongly emotional. Completely opposite. We don't want to get the patient too emotional. We don't want them to talk about it in detail. We talk more about, it's a bit more like being someone's favorite nurse. And you might think, like, have you ever been to have, I don't know, the COVID vaccine, for example? Some nurses are just really good, and no one likes having a vaccine and a needle taken, but they will talk to you, they'll be quite jolly, they'll tell you what to do, and they'll be quite simple about it. And I guess when we're doing this intervention, we want to bring that positive spirit and keep it simple and effective and brief. And by doing that, you're helping the patient learn to use that tool themselves and to be able to do it again when they have another intrusive memory. Why is it so important it's repeatable? Well, I guess learning what we're doing so the patient can do themselves feels very important in an ongoing war, because there may be new traumas or other traumas that haven't been treated. So that's why I want to try and make it as simple as possible. So what I wanted to do now is just show you a little bit about the journey behind this and what the evidence does and doesn't say so far. So first of all, we worked on developing this in the laboratory and using film material. And the reason that's important is that lots of people are watching films of war and trauma. So it also works if you're watching trauma in the media, like the ongoing media exposure to Ukraine. We have also worked with patients very soon after a real trauma early on. This is in the emergency department of a hospital in a busy, chaotic situation. So actually in the middle of whilst they're waiting. And we repeated and found a similar pattern result when we used it with patients in both England and this one is in Sweden. And we found that one dose for one trauma was still bringing memories down a month later. Beyond this very soon after trauma range, we have worked with patients with, but this is a case series, so small scale work, but with case series with complex PTSD who were inpatients who didn't want to talk about their trauma. So it was an acceptable method that they could do that. And in this case, they did the memory reminder cue, not by saying it to the therapist, but by writing it on a piece of paper that the therapist wasn't allowed to see. In fact, they could just keep the paper themselves and then do it. So being a therapist, you need to be creative about how to get a minimal reminder cue that just brings it into mind, but no more. It's not extremely distressing. This picture I wanted to show you just about the concentration disruption of having one intrusive memory of trauma and why for some people it can be very motivating. And the more intrusive memories people have, the more their concentration in daily life is disrupted. So for most people, having a memory of trauma doesn't just disrupt you for the few seconds you have it. It disrupts you either for 1 minute, 5 minutes, 10 minutes, half an hour, up to an hour after a flashback. So if you're having 10 intrusive memories a day or 5 intrusive memories a day, that's an awful lot of your day that's being wasted and taken up by this phenomena. And I think that gives people a lot of, once they realize it's very treatable and they get rid of it, it can give refugees a real positive boost to get rid of this concentration disruption problem. And the reason I emphasize that is it's less stigmatizing to talk about this will help you improve your concentration, because again, that's a way of focusing on the positive benefits of an intervention rather than this intervention will make you feel less distressed. Most people who are refugees have survived against the odds to get somewhere safe and identify as survivors rather than only want to talk about distress. So we've certainly found that focusing on the positives about concentration coming back has really helped, particularly with young people and working with young people. So if you're interested in this, and I'm aware of the time and we need some time for questions in a moment, but there's some work that we've reported, and this is just tracking diaries, just showing how one dose of doing something can bring memories down from many times a day to less. And focusing on the functional gain seems to be what's most important to the refugees that we've worked with, albeit at a small scale so far. It's helpful in the moment. Doing this kind of intervention to compete with an image is a positive distraction just by doing it. And the fact it also stops intrusive memories returning can also be helpful. So here's someone's quote: "When I played it, I zoomed in, it could help me concentrate. I forgot about that memory. It felt joyful, like my memory was getting busy with something else, and I could instead think about that." It felt good in the moment. It helped someone sleep. And people also talk about when the intrusive memories start going down, they can start to think more positively about the future again, become more optimistic. Refugees that we've asked in focus groups have liked the idea of just doing one thing at a time. It's simple, one symptom at a time. And the fact that because you don't have to talk about the trauma in detail, you can do it in a public place like a library without it being embarrassing or worrying about confidentiality. And some people have learned how to do it, and not only in their own work, but told their friends how to do it. And they've been able to use it. So if you want to find out more about that, the practitioner messages in the paper, I'll show you the references at the end of these slides. And I've shown you that already. So what I've also mentioned, just to end on, is that imagery doesn't just come from real trauma. We can also acquire intrusive imageries from war-related trauma that's exposed to us all the time in social media, in the TV. Behavioral limitation is clearly the best thing to reduce that, but this kind of technique can be also useful to reduce intrusive memories after media exposure of traumatic events. And I'm sure that's something we're going to have to think a lot more about as the war continues, particularly for children, and limiting the time they spent viewing it. But all the techniques I've told you. So thank you very much. I think I won't sum up again in the interest of time. But I do think we need more preventative and scalable interventions, and I welcome the chance to continue discussing this with you and develop things that are suitable when you're taking a huge number of refugees into your country. So I hope we can land in the idea that let's be optimistic. Sometimes simple things can be powerful, and we should be asking ourselves, what is the least we can do to make a real difference, and work together to strengthen the evidence base, not for now, but just the years to come as well. So thank you. And these resources you'll find at the end of my slides that give you the references to the papers, the books, and the videos if you want to see some case presentations. So thank you very much from me. And I'll take it off stop share.
Bardzo dziękujemy i dziękujemy za taką...
Thank you very much. Thank you for this vaccination of knowledge and practical skills, and some hints and some questions appear on the chat. But let me first ask from the clinician point of view, when sometimes we experience, we only have one opportunity to meet our patient, and if we wish, in fact, to educate patients in terms of the interventions, I mean the vaccine, but also to make sure that the patients are given clear guidance on how to proceed on their own. So what should we concentrate on? And I think, and also how to make people more determined on to fight against the disorder. Could you give us some advice on this, please? So what should we tell our patients, in fact?
What should we tell our patients? I think we should always be optimistic and tell them that intrusive memories are very treatable, and they're just memories of trauma, and thousands and thousands of people have got rid of their intrusive memories before, and this person's going to be able to, because often the person doesn't feels out of control. And then I think we can just tell them what they are and define them so they understand their symptom, like we discussed earlier, so that they're images, and how they arise, and that the brain's trying to keep them safe, but it's gone out of control. And then give them very simple techniques. So I think if you've only got one session, I would always start with the most simplest, evidence-based. It's not real. Metacognitive appraisal. You can do a very simple in-session experiment, getting someone to change their image. if you want to use this novel technique, as I said, I think it will take you at least a session to explain. So maybe practice doing that and talk about how you bring it to mind and can bring it down along. Do you think that would be helpful?
Super, bardzo dziękuję.
Great, thank you. We have some more questions in the Ukrainian language. Can we ask, please, for translation from Ukrainian?
So, Emily, did you hear the question?
No.
Because if I got it right, there was a question about what is the risk factors for very many intrusive memories. If there are too many of these intrusive memories, what could be the problem with them?
Okay, so the biggest...
If I got it right, sorry, because...
Great, that's a really great question. The biggest risk factor for intrusive memories is the number of different traumatic events that someone's been through, which is why as the war increases, people might have more and more intrusive memories over time, unfortunately. The second type of risk factor is that there are certain psychological disorders associated with a vulnerability to intrusive memories. And they include probably the one that we think is the most highest risk is bipolar disorder, have a huge number of, because they're very high images, intrusive memories. But also, we've also shown in other research that people with an existing anxiety disorder also, and depressive disorder also much more likely to have intrusive memories. People with borderline personality disorders can also have a lot of intrusive memories. But they're treatable. So it's good to know the risk factors and good to know that the treatment's the same regardless. In bipolar, in fact, one of the most powerful techniques, and we've written a book that includes this for intrusive memories, is to learn that the memory is not real, because people doesn't even occur to them. It feels so real. And that really helps. I can see questions coming through in the chat, and I'm so sorry, I can't read Polish or Ukrainian.
Pojawia się jeszcze pytanie, jeżeli minął 1 miesiąc od traumy, czy ta technika może być stosowana?
Yes, so the question is, if more than a month passed from the trauma, can we apply this technique? Is this going to be efficient?
Yes. So as I said, we only have randomized control trials on the early days after trauma, but we have evidence in case series showing that 20 years since the trauma, patients were able to reduce the number of intrusive memories they had of complex childhood trauma. And I think as far as your brain concerned, a memory is a memory. So even for much older traumas, we can use these kinds of techniques to bring down the number of times people have intrusive memories.
Emily, in one of your slides, there was something to do with hot topics in dark times. That's a very, very interesting area. In fact, your talk seems to be incredibly exciting. It must be exciting research that you're doing, demonstrating that really just simple exercises can make such a powerful influence on, you know, this suffering that people experience. I wonder, where could you remind us where we could read a little bit more about this research, because it's very, very straightforward in some ways, and we can perhaps use it as quickly as possible. Yes.
So this was the slide that you meant about the hot topics and dark times. And the reason I put that up is because my colleagues, when I went to Ukraine in 2018, I met my colleagues Irina and Oleg there, who run this talk series, and that's where you can find that. But I think the bits you need to look at is not what I say, but what they say. So Sophia talks about a case here using this technique, but with a case with borderline personality disorder. And then my colleague Oleg, who's a head of department there, talks about how he uses it himself when he is sheltering in a bomb shelter during the war in Kiev, and how he's used it with his patients. So I think that's one place to look, because people using it is far more convincing, I think, than me trying to explain academically. And I guess it's sobering. I guess as clinical psychologists and CBT therapists, we need to be really careful not to move faster than the evidence base. But that's why I've tried to show you what evidence we do have and say this technique is still very early days. It's at proof of concept days, but it feels if it is simple enough to use under war situation and people are monitoring it and finding it helpful, then I would share these techniques if it's useful, absolutely. But we do need more research. And I think maybe what we could be optimistic about is the potential now to try and help people even on ongoing situations. So yeah, I would welcome more research by other researchers too in this area.
No. Thank you very much for this really inspirational talk, and so much to think about how yes, we can look for simple measures, simple but effective, how we can have to observe our clients and see what is the effect on them. Anything that would alleviate their suffering would be incredibly helpful. So we look for these sort of tools. And thank you very much for sharing and inspiring us to observe, what could help.
Well, thank you for all you're doing in Poland.
And Emily, thank you very much for your talk tonight. I don't want to, take it even further, because I can see that there could be so many issues, but maybe we could meet again, maybe around November, your trip to Warsaw. Yeah. We could go back, maybe you could have some more research data and we can continue with looking for ways, as you were saying, different ways that could really affect these people that we're working on. So thank you so much for this help.
I would love to stay in contact. Again, thank you for all you're doing. And if I can help in any way, I'm more than pleased to. So thank you to your association.
So thank you very much to everybody for your presence, for your participation, for serious thinking about how we can help people in such a terrible situation. And we hope to see you again, maybe tomorrow. We shall focus tomorrow on slightly different subject, on how to care about ourselves in this very, very difficult, demanding situation. And if it is okay, Emily, I would share with the participants of today's talk, your talk, this slide with the research data and reference to your research. So if this is okay, I would send it to the participants, this one slide. Would this be okay?
Sure. But why don't I make a PDF if you want, or if there's any resources I can send you, just let me know. But we can maybe stay on afterwards and I can prepare something for you.
Wow, yes. If this is if this is possible, then we always want to share as much as possible, because we're really doing tough job, and we want to make it available as much as possible.
You are doing a tough job, and I'm glad to hear you're doing a session looking after each other. That's really good.
Okay.
So important.
Szanowni Państwo, wysłałam Państwu ten jeden slajd.
Ladies and gentlemen, I have just sent you just one slide discussing this very interesting study, and I hope that we will be inspired to creatively but also carefully. So this is what Emily was telling us, that we need to be careful and we need to observe what is happening with our patients and the patients we are working with. Thank you very much for your participation. Thank you for your presence. Thank you for your willingness to spend your time and to learn new things and new ways of work. And Emily, hopefully see you again in November. This will be a really interesting and important and helpful. So as you can see from Imamora's, thank you.
Okay, thank you.
Good research, good research. Do wonderful research in your work, and thank you for sharing all of this.
Thank you.
Dziękujemy bardzo. Dzięki, do widzenia.
Thank you, and good night, ladies and gentlemen.